Good evening and welcome to the Prolonged Ventilation webinar as a part of the STS Quality webinar series. This is the fourth installment in this wonderful series, which has previously included blood conservation, glycemic control, and mediastinal staging for lung cancer. The Society has also assisted us with webinars on public reporting for both adult and congenital cardiac surgery, and all of these can be found on the website. I want to begin by thanking the Task Force on Quality Initiatives, which is chaired by Rich Prager, as well as the various members who've been incredible help throughout, and the speakers. I'd like to thank the full-time staff, as well as Duke's Clinical Research Institute. My name is Kevin Lobdell, and I'm the Director of Quality for Sanger Heart and Vascular Institute in the Carolinas Healthcare System. I have no disclosures. Tonight we'll have a brief overview of relevant STS data from the time period of July 2011 till December 2013. And subsequently Glenn Whitman from Johns Hopkins will discuss improving early extubation rates. Subsequently Bill Kane from Intermountain Health will discuss prolonged ventilation improvement efforts, and we'll end with a question and answer period. Our review of STS data for prolonged ventilation after isolated coronary artery surgery included 1,082 sites, 356,176 patients. None of those patients were intubated prior to the operating room. And again, all of those patients who will be defined as prolonged ventilation had ventilation times greater than 24 hours. We found that the early extubation rate in the aforementioned time frame was 42%, and there was considerable variation around this mean with standard deviation of 20%. 10% of patients suffered from prolonged ventilation, and the standard deviation was 6%. Isolated prolonged ventilation was 4%, and complicated prolonged ventilation, or those cases where prolonged ventilation was associated with other complications, was 6%. Mean reintubation rate after isolated coronary artery bypass grafting was found to be 4%. Interestingly, the reintubation rate after early extubation was 2%. And it is noteworthy that reintubation rate is approximately a third of patients that suffer from prolonged ventilation. ICU readmission rates are 3% after coronary artery bypass grafting, but 28% in those requiring reintubation. Similarly, 12% of patients are readmitted to the unit when they suffer from prolonged ventilation. The Virginia Cardiac Surgery Quality Initiative shared the financial impact of prolonged ventilation on isolated coronary artery surgery, finding that it adds approximately $41,000 in cost to an otherwise uncomplicated operation. Next, Glenn Whitman will share the Hopkins experience on early extubation, and as he completes his talk, we'll transition to Bill Kane, who will share the Intermountain Health Quality Initiative efforts on prolonged ventilation.
It's my pleasure to be here this evening to talk about early extubation rates and decreasing the time our patients spend on the ventilator. I have no disclosures. Early extubation rates are currently a trackable measure in the cardiac intensive care unit. We are not yet held responsible for them, but we do have to report them. I thought it would be worthwhile, though, to go over how early extubation rates came into being, as well as what are the benefits to making it happen. This paper out of the Sanger Institute several years ago looked at 2,700 coronary bypass procedures. 42% of their patients were extubated in less than 6 hours, and they decided to take a look at what might be the benefits associated with that early extubation. When they determined the propensity matched group and analyzed the associated improvement in patient outcomes that were associated with early extubation, the results were really astonishing. From renal failure to infections to ICU outcomes to mortality, patients did much better when extubated early. In this study from the University of Alabama, the effort was made to show that even in the elderly, early extubation was safe. They looked at patients who were over the age of 65 and compared those extubated in less than 6 hours to those extubated between 6 and 12 hours. What these authors showed in these 3,000 patients was that there was no harm created by extubating these elderly patients early. In fact, the benefit that was associated with early extubation seems to be that of improved efficiency of care with decreasing length of stay. Clearly, from those two studies, one recognizes the benefits to early extubation. For certain, it's not harmful. Possibly, as with the first study, it's extremely beneficial. There is a meta-analysis looking at early extubation after adult cardiac surgery that was published in 2012 as a Cochrane systematic review. The review points out that although there are 30 studies looking at early extubations, there are very few that are controlled. The review, in fact, looked at 6 trials that they felt were worthy of analysis. There were 871 patients. Most of them were coronary bypass surgery patients. And what these authors found was as follows. First, there was virtually no increased morbidity associated with early extubation. The mortality rate, post-op MI rate, and post-op stroke rate, as shown in this top graph, were not different. There was a higher reintubation rate in the early extubation group, though. In terms of efficiency of care, early extubation is significantly better than extubation along no particular pathway. And what can be seen here is that in patients who were subjected to early extubation protocols, there was a 8-hour improvement in time on the ventilator. ICU stay was also around 8 hours less, and the length of hospitalization was approximately a half a day less. And so from this study, one recognizes that although it's questionable whether early extubation improves postoperative morbidity, it's clear it improves the efficient delivery of care. I thought it might be worthwhile at this point to talk about what are very clear benefits associated with getting off ventilators early. The Sanger paper points out some, but this is data from Johns Hopkins over the last couple of years looking at 2,200 open heart surgery patients. This is all comers, and one can see when one looks at infection rates with respect to ventilator time, the dramatic association. Here, there's really no difference in the first 12 hours regarding post-op infections with a rate of around 2.7%. But as soon as you get to 12 to 24 hours and then 24 to 48 and greater than 2 days, the incidence of infection rises exponentially. In patients on the ventilator for more than 2 days, the incidence of infection is 36%. But just being on the ventilator 12 to 24 hours seems to double your infection rate. In this slide, I show the relationship between post-op surgical site infections and pneumonia as a function of ventilation time. The point I wanted to make on this slide was 1, 50 to 60% of all postoperative infections are the result of pneumonias, and these relate dramatically to ventilation time. And 2, surgical site infections also are associated with ventilation times. At this point, let me share with everybody what I think are the keys to performance improvement in a hospital setting. I think a physician leader is critical, but I also think that there must be a multidisciplinary group. I think that everybody needs to feel equal, and I think that the group needs to have a common vision and measure what it's trying to improve. In fact, our cardiac intensive care unit has its own quality assurance performance improvement committee dedicated to the CVS ICU, and here's an example of the kinds of topics we find interesting and want to improve upon. This is a living document. It changes month to month, but this is an example of what it looked like a few months ago. And in fact, it was at one of the QAPI or QAPI meetings that we recognized in 2008 that our early extubation rate was absolutely horrendous. Here you can see the data showing that we extubated only 16% of our patients in less than 6 hours compared to STS-like institutions at 22% and at a nationwide level at 30%. Given this horrendous performance, we hypothesized that we could improve early extubation by, one, all agreeing, and when I say all, I mean all of the attendings and providers in the unit agreeing to extubate in the same manner, and two, allowing the nurses and the respiratory therapists to have the responsibility for moving the process along rather than waiting for the providers to forward the process. This is the protocol that we adopted. There's nothing earth-shattering about it. We reversed patients at 36 degrees, but most importantly, what was involved in this protocol was that nurses and respiratory therapists carried it out, that physicians were relatively uninvolved until the very last minute when the decision to extubate and give the order was ours, and then perhaps most importantly, that all of us agreed to do it exactly the same way. And this slide shows incredibly what happened within the first 10 months of adopting this protocol. You can see that we doubled our early extubation rate from 12 to 24%. Not great compared to the country, but certainly deserving of the most improved player award, at least in our minds. But still unhappy with that overall performance, we hypothesized that if we reversed the paralysis earlier when patients were a little bit colder, and if we came up with some way of reminding ourselves constantly during the early postoperative period that this patient needed to be extubated, we could improve our performance. And consequently, we reversed patients at 35.5 degrees, and we created a pink reminder sheet that noted the time of the patient arrival in the ICU, what time it would be 4 hours later, and what time it would be 6 hours later. By placing that pink sheet on the door of the patient's room, we hope to continually remind ourselves that time was passing and that we needed to get this patient extubated by a certain time during the day. I would point out that when we first started this, we were mistaken in when the clock started running. In fact, according to the STS, the clock starts ticking as the patient is wheeled out of the operating room. We initially started our clock ticking when the patient came to our ICU, which in some instances could be as much as 20-25 minutes after the patient was wheeled out of the operating room. And this slide shows what happened during the next several months. You can see that now in period 3, we had improved our extubation rate to 38%, which was probably no different from the nation as a whole, which again pleased us tremendously. It may have been only average, but for us it was a tremendous accomplishment. Unless we attribute to our protocol powers that really were not its due, we did a regression analysis holding constant factors that we thought would be relevant to early extubation, as you can see here on this slide. And what it shows in the lowest 2 rows is that holding all things constant, just being in period 2 or just being in period 3 led to a more than 2-fold or a more than 4-fold increase in our early extubation rate. It was this kind of analysis that allowed us to believe that, in fact, it was the protocol that was driving this improvement in our rates of extubation. This slide shows our current performance, and as you can see, it seems to have just continued to improve and taken on a life of its own. We are at the 50% mark for early extubation. Again, only moderately above average, but it continues to improve and has been a total success in terms of performance improvement initiative. This slide shows our median ventilator times over the past 5 years, and as one would expect with our improvement in early extubation, our median vent times have improved as well. This slide shows what I continue to believe has been crucial to our success, and that is showing ourselves the data. And here you see in the left-hand bars what our early extubation rate is, both for the year in blue since January 1st and how we behaved in terms of our coronary bypass surgery patients last week. And on the right-hand side, we show ourselves similarly the percentage of patients for the year that have had coronary bypass and been extubated in less than 24 hours, and how we behaved last week. We show ourselves this every week at our morbidity and mortality conference. We continue to believe that there's low-lying fruit to be had regarding early extubation. This slide shows the arrival temperature of patients in our ICU, and as you can see, last April we started measuring this. 1 out of 5 patients came to us at less than 35 degrees. We now have it down to 1 in 10, and we think this is going to be instrumental in allowing us to extubate sooner. And this slide shows the arrival base deficit in the ICU. We're using it as a surrogate for hemodynamic and volume resuscitation that could occur in the operating room before the patients arrive to the unit. The concept being that the smaller the base deficit, the better the patient has been resuscitated from his separation from bypass, and the quicker we can move the patient along the path to extubation. Finally, in terms of opportunities in the future, this is a multidisciplinary group, and our anesthesiology colleagues are, even as we speak, looking at their intraoperative protocols to see if by manipulating them, they can prepare patients for even earlier extubation. And on a separate front, we have created a survey for our patients to better understand their experience with being on the ventilator early on, with the hopes that we can prove that patient satisfaction is dramatically improved with earlier extubation.
Hi, my name is Dr. William Kane, and I'm a cardiothoracic surgeon at Intermountain Medical Center in Salt Lake City, Utah. I have nothing to disclose. By way of introduction, Intermountain Medical Center is the quaternary referral center and flagship hospital for the Intermountain system, which includes 4 cardiothoracic surgery programs across the state of Utah. As we began focusing on our STS outcomes data several years ago, nothing was impacted more than this prolonged ventilation measure. Prolonged ventilation is defined as a total intubation time greater than 24 hours following exit from the operating room. And if you ask my colleagues, none of us felt that our intubation times were excessive. But as we looked at our STS database information, that data suggested otherwise. Consequently, it has made a big difference in our practice. As we reviewed our initial public reporting data, we were surprised to see that our avoidance of morbidity statistic was significantly lower than we expected. As we reviewed the data in more detail, it was clear that prolonged ventilation was far and away the most significant complication our patients experienced. So we worked together and set a goal to try to extubate as many of our patients as possible within 6 hours of surgery. You can see that during the first 3 years of this effort, we made significant progress in this regard. You can also see that we did a good job of moving patients through our intensive care unit with a much lower than average percentage of patients spending more than 24 hours in the intensive care unit. However, we were disappointed to see that in this subset of patients who were difficult to extubate, our outcomes were actually getting worse. We realized as a referral center that some of our patients were very challenging to extubate. This included patients who were on mechanical circulatory support and even intra-aortic balloon pumps. Our habit was to keep ballooned patients intubated until their balloon pump was removed so that we could sit them up at the time of extubation. We also have patients referred to us who have very poor ventricular function, patients with severe lung disease, and patients who have post-op delirium or patients who are alcoholic and have to withdraw prior to extubation. Nevertheless, we recognized we needed to focus on extubating our patients sooner because several patients in the literature, including this one from Dr. Lobdell's group, suggested that outcomes were improved with earlier extubation. We decided to review our own data here at Intermountain. So we took a sample of 6,326 patients undergoing isolated coronary bypass surgery. And on this table, you can see the two shaded columns are the patients who were extubated within 6 hours of surgery and the patients who were extubated in more than 6 hours after surgery. And the mortality rates of the patients who were extubated early were significantly lower. The problem with reviewing data like this is that it's nearly impossible to demonstrate causality. In other words, does early extubation cause improved outcomes, or is it merely a marker of a less severely diseased patient population? But as we broke this data down into STS preoperative mortality risk profiles, it was clear that in every category but the highest risk patients, early extubation was associated with lower mortality rates. Therefore, we wanted to do everything we could to make our patients look like the patients in the early extubation category, where possible. So how do we go about tackling this problem of prolonged ventilation? Well, first of all, as I noted above, it's simply identifying prolonged ventilation as a problem in our practice. Again, that was something that none of us really realized, but the STS data really pointed that out to us, and I think much to our patients' benefit. Therefore, we appointed responsible people in the surgical group, in our cardiovascular critical care group, in our respiratory therapy group, and in our intensive care unit nursing group to be responsible for this measure. Importantly, though, it's ideal that everyone's enthusiastically invested in improving this prolonged ventilation problem, and everyone then shares the benefits of these improved outcomes, especially our patient population. From the standpoint of surgeons in our group, every one of us is engaged in process improvement. We don't simply delegate that to other people. And all the surgeons and mid-level providers frequently stress with the staff the importance of early extubation of our patients. We've had a monthly process improvement meeting for many years, which is the perfect forum in which to review our progress on this and other goals. And we've established protocols which have empowered our intensive care unit nurses and our respiratory therapists to drive this early extubation effort. Of course, early extubation begins in the operating room. So we looked at the data from each of our cardiovascular anesthesiologists, wondering if we needed to mandate a certain anesthetic technique. We found that although each of them used slightly different methods, their outcomes were consistently good, and therefore we saw no reason why they couldn't continue to use the method with which they were most comfortable. We educated our intensive care unit nursing staff about why we thought early extubation was an important goal to achieve, and we encouraged them to partner with our respiratory therapists in this effort. Our respiratory therapists worked together with our intensive care unit nurses to extubate most of our uncomplicated patients within 6 hours. The time each patient had been on the ventilator became a part of every handoff at change of shift. Our lead respiratory therapist really ensured that all caregivers were really educated as to the rationale for this goal and also motivated to achieve it. Then she would follow up on all extubation times and give appropriate feedback to each caregiver and review each case in detail at our monthly process improvement meeting. We're also fortunate to have a great group of cardiovascular critical care physicians who will proactively consult on any complicated patient who seems to be taking long to extubate. They are kind enough to do an ongoing review of the progress of all of our patients in the intensive care unit, and they intervene where it's appropriate. Cardiac surgery, as they say, is a team sport. A 2008 study from California demonstrated that there was no significant mortality difference between patients operated on by high-volume versus low-volume surgeons, but there was a significant difference in patients who were cared for in high-volume versus low-volume hospitals. This tells me two things. One, that our training programs turn out consistently good cardiothoracic surgeons, but two, we rely on physician assistants intensive care unit nurses, respiratory therapists, and many other team members to ensure our patients have good outcomes. So as we review our most recent STS data, you can see that with the assistance of every caregiver, we have continued to make improvements in early extubation of our patients. And we are finally making an impact on the subcategory of patients who are most at risk for prolonged ventilation. As you can see, this curve has its ups and downs, but our trend is in the right direction. Clearly, a continued focus and constant vigilance will be necessary in order to make sure that our outcomes continue to improve. In summary, the take-home messages from our experience are that the first challenge is to recognize prolonged ventilation as a problem. Next, when taking care of these challenging patients, it's reasonable to extubate patients with a slightly lower pH if they're otherwise doing well. More importantly, though, it's very important to avoid compromising clinical care in order to achieve the goal. In other words, it's not a good idea to extubate a patient to high-pressure BiPAP in order to make the numbers look good. We found it was much more effective to change the culture, to change the mindset that we would just leave them intubated overnight, for example, and also to avoid suspending the process of weaning from ventilation at shift changes. Focusing on ventilation times during every nursing and respiratory therapy report at change of shift helps keep this goal in the forefront of everyone's mind. We also found it was important to avoid continuous benzodiazepine and narcotic infusions wherever possible in order to facilitate ventilator weaning. It's then important to focus expertise and resources on the patients who are still intubated on the morning of the first postoperative day. Accountability, feedback, and case review are essential to process improvement. And the process of team members pushing each other to improve clinical care is very gratifying. And lastly, remember that the minute the patient hits the intensive care unit, the clock is ticking. Everything we do in the care of that patient should be done with the goal of early extubation in mind. Thank you again. I appreciate this opportunity you have given me to share the experience we have had as we've strived to improve our extubation times at Intermountain Medical Center.
In order to listen to the Q&A session, dial 1-800-250-2600, PIN number 920-23707, and we'll select your questions and provide appropriate answers. Thank you for joining us.
How many hours is considered early extubation? It's simply 6 hours. Was there an increased rate of pleural effusion noted with early extubation?
This is Bill Kane. No, we haven't noticed anything like that I can think of. Is there a specific reason why?
Simply that question, if anybody saw an association.
I'm guessing it's a concern about less positive pressure, perhaps causing more effusions, but we haven't noticed anything like that.
Right, and I can speak from our experience. We've studied both phenomenon, have not found an association. A good question, and it may be worth looking into a little more deeply since somebody raised that question. On the slides, you noticed an increased hospital-acquired infection rate with increased ventilator time, and the obvious question then was, do we see an improvement of the hospital-acquired infections with decreased ventilator time?
We certainly have noticed that our hospital-acquired infections have been improving, but we've been doing several things in that regard, so I can't specifically say it's tied to ventilators. Glenn's data demonstrates that very well. I'm sure that's generalizable data.
Yeah, I think our trend has definitely been as you described, which is as we improved our early extubation, we saw a decreased rate of hospital-acquired infections, pneumonia, catheter-related bloodstream infections, but it's been a multi-pronged effort, so to say it's merely associated with early extubation may be difficult. What are the most challenging roadblocks encountered when implementing new efforts and protocols?
the challenges or the roadblocks can be as varied as there are people involved in the process. But again, as I think we've all sort of alluded to, trying to make early extubation work is a team effort that requires, people from several different disciplines to work together. And the most important thing was helping everyone understand why it was an important effort in the first place. And then once they understood that, and once they understood that it would improve our patient outcomes, I think it was easy for everyone to try to work toward that goal. And it's, as I said in my presentation, it's kind of fun for everyone to work together to sort of push each other to do better, and it's fun to measure our progress and see improvement.
The general question of anything that you might do, and then specifically related to that, anything about head of bed positioning.
We typically like to have the patients at least at 45 degrees when we extubate them, and so our habit for many years, our practice was to leave patients with balloon pumps intubated until their balloon pump was removed. And so we still feel that it's not good practice to extubate somebody who's lying flat on their back. So the way we've worked on this is, first of all, we've often just pulled the balloon very early, sometimes even the evening of surgery. If it went in for chest pain before an operation, then we'd take it out as soon as the patient was back in the ICU. Now, if it went in for post-cardiotomy problems, obviously you can't do that. But we've also, when people were otherwise stable and seemed to be able to be extubated, we sometimes will just put the entire bed in reverse Trendelenburg, so that they're more or less head up. We obviously can't get to 45 degrees, but we do our best, and we have extubated a couple of people who have balloon pumps in that setting.
Is an obstacle along the way that one learns from, but I think much like you, we, in those patients that had balloon for chest pain, tried to get them out early and even before extubation. Those that were for myocardial performance, whether it was just a chronically low EF or an intraoperative problem, you had to really get an idea of what sort of inotropic support was required, how stable were they otherwise, and then much like you, we would use reverse Trendelenburg and try to sneak them up a little bit, but clearly not in a sitting position. Zeroing in on the hour of extubation or even minutes, and do you find a difference hour by hour, or can anybody say that 5 hours is better than 7 hours type thing? Do you have any experience with that?
That's a tough one. I think Glenn's data looked at, I think showed that they found a difference after 12 hours, and we haven't drilled down that closely. I think, though, that as I showed in our data, clearly we sort of arbitrarily picked a number that's talked about by many other groups, and we certainly found that if we used 6 hours, that our patients did much better if they were able to be extubated before that 6-hour window closed.
Yeah, very good. I think one thing that we found, and it kind of relates back to the question about barriers and human performance and so forth, I think one of the values is it's a common goal and people start to learn from it and improve it. Along the way, we found that people did have a question like, how do you come up with 6 hours? Isn't it somewhat arbitrary? Well, it certainly was something that was handed to us, so we worked with it. We subsequently studied it, and I know it's somewhat simplistic, but what we found was all the extubation times prior to 9 hours were considered equally good, and then you started to see a change in your outcomes, and by the time you got to 16 hours, we thought that they were statistically significantly different. So I don't know that you can measure these differences in minutes and hours with the numbers of patients we're talking about, but those are good questions and good things for us to all think about. Another good series of questions are being asked about analgesia. Could you address your thoughts there, William?
Like I mentioned in our presentation, I think the biggest thing that we try to avoid is any narcotic or benzodiazepine drips. And one of the programs in our system uses a lot of Presidex, and we never use it. It's sort of a practice thing. But, I think all of our anesthesiologists, like I said, early extubation begins in the operating room, and they all use their various techniques to make sure that the patients are, essentially starting to wake up and move around basically the minute they hit the intensive care unit. And I was interested to see in Glenn's information that, sometimes their patients come back quite cold. And, we've used fluid warmers, and we have the patients lying on a warming mat on top of the bed to try to keep them warm after we come off bypass. We always, of course, want to come off bypass close to a normal temperature, and then that's helped us to keep them that way. And so it's nice if they can come back and they're warm, and then the anesthesiologists are always working hard to make sure the acid-base status is good. And basically all those things you can do in the operating room make it much easier on the staff in the intensive care unit. And typically for early post-operative pain, we'll use intermittent dilaudid or something, to try to help control that, but no magic or no magic drug.
Glenn, could you address your thoughts about analgesia in the post-operative period?
I think that when we are increasingly keeping patients on a low-dose fentanyl drip post-operatively, everybody comes out on propofol. And after we reverse them and we think that they're hemodynamically stable, and remember we reverse at 35.5 degrees, and then we think that they're hemodynamically stable, we'll turn the propofol off and we go through our weaning process, which is all driven again by the RT and nurses. But we have anecdotally had people, when the propofol gets turned off, extremely uncomfortable with the tube in place. And we're working on what's the best way to keep a person comfortable with the tube in place. And one surgeon says, well, when they wake up and they're uncomfortable and the propofol's off, then just pull it. That is an approach. We haven't adopted that. We think that they really do need to show that they may be uncomfortable, but they've got to be able to ventilate. And we think that keeping them on a low-dose fentanyl, and I'm talking about 10 or 20 mics, might make them more comfortable. But just going cold turkey every once in a while, I think, hurts a patient, if not contributes to some sort of post-traumatic stress disorder. And I don't know that for a fact. It's one of the things we're trying to get a handle on with that survey. But it's one of the things we're struggling with.
That's very good. I might just add that we routinely monitor the dosing of fentanyl Versed in the operating room with the idea that if we can manage that, we're set up better to extubate early. The routine drug is intermittent morphine, and if somebody we think for whatever reason is a little bit more of a challenge, we'll use Precedex, not only for the sedative effects, but a little bit of analgesia. But it sounds like we're all thinking about the same things, so thank you very much for that.
Can I say something about Precedex?
Yep.
Precedex is, first of all, extremely expensive, and secondly, I'm interested in everybody's experience, but we have a tremendous amount of hypotension. So because of the expense, and because hypotension is something that we are dealing with increasingly for this vasoplegia for reasons that I don't think any of us understand, we haven't used that drug.
Yes, you're right. It is an expensive drug, and we tend to use it PRN. I think that there have been efforts to try to increase the use from various institutions and certainly from drug companies, but we've tried to just use it like any tool in the toolbox where it's best utilized. Have you noticed any difference in early extubation rates as they may relate to volume and volume changes in off-pump coronary versus on-pump coronary?
Oh, no. Only 3% of our patients are off-pump. So, no.
Yeah, we did a fair number of off-pump procedures several years ago, but have pretty much gone back to almost exclusively on-pump coronary surgery. And so I'd say, no, we didn't notice anything. Could I ask, just you sort of alluded to it with the last answer, but I was wondering, Kevin and Glenn, do you think there's such a thing as too early extubation? Do you ever extubate your patients in the operating room, for example, and what are your thoughts about that?
I do think there's a problem with too early extubation. I can't prove it, but I know what it feels like to struggle with someone who gets extubated early and they're 7.26 with a PCO2 of 55 and hypotensive on drugs, and you're putting CPAP on them, and I think, why did we do this? We knew the gas was marginal to begin with, and we went ahead and extubated, but I can't prove it. We have a 1.4% reintubation rate for our early extubations, which is similar to that 2% that I think Kevin showed us in one of his initial slides. But yeah, I really want patients to ventilate. Bill, you're pH is 7.30, it's sort of a line across which we don't go. If during your weaning trial your pH drops below 7.30, you don't get extubated. Something like that.
It sounds like we've all coalesced around similar views. We have had very few that were extubated in the operating room. I've found it a challenge, everything from thrashing to overly sedate. It doesn't give you time to get postoperative films, ascertain that we're not bleeding, oftentimes chasing hemodynamics. With respect to those that are not extubated in the operating room, but early, the numbers are small. But in our evaluation, as we looked at hour by hour, we did not see any problems with it. In other words, no time was too early, but that study would not have been designed or powered to answer the issues or address the questions that you just brought up, Glenn. And I would reinforce that I share the same view that you described. There's a question about any sort of aids or techniques for high-risk patients in early extubation.
Our respiratory therapists, our ICU nurses, and when we have, someone who's high risk, we'll often have one of our critical care physicians involved as well. And that's probably the biggest thing that we do differently in high-risk patients is we have a critical care intensivist involved with them early on to help manage airway and other issues. But with most of our routine patients, our critical care physicians aren't involved.
No, we don't have anything. I don't know of any technique, none that I know of.
Here's a good question about common goals and guiding coalitions. I'm sure we've all faced this with a variety of different challenges, but tonight we're talking about early extubation, prolonged ventilation. Question relates that the respiratory therapists are gung-ho to lower vent times, but surgeons are resistant. Do you have any suggestions?
Our surgeons don't suffer from that problem. They want those tubes out as fast as they can possibly get them out. When we take a tube out and we start struggling and one of the surgeons comes by, he suffers with us, but all 5 of our surgeons are really pushing to get those tubes out. They think that they're uncomfortable for the patients, and they recognize, as I think we pointed out in the slide portion of the show, that there are real benefits to early extubation. So, no, our surgeons, they want that tube out any time of day or night. They want that tube out.
Just to extend your comments there, I think within your talk, you talked about an educational period. You looked at data, manuscripts, and you must have shared that with your colleagues along the way. Is that accurate?
Absolutely. And as you heard, that they see what's going on for the year and every week last week at M&M, so everybody gets a chance to add his 2 cents about how we're doing and whether we're pushing the boundaries too far. And it gets a 5-minute conversation every Thursday morning.
Let me ask you a question, because I think what we've all said in our own way is we've learned how to extubate early and improving the avoidance of the prolonged ventilation. Do you have a good feeling, other than just somebody fails the obvious criteria, of who shouldn't be extubated early, or any clues?
An ongoing unexplained acidosis, even an ongoing explained acidosis is a contraindication. As with Bill, balloon pumps no longer are contraindications. We just pull the head of the bed up and lower the feet as much as we can. But I think in high-dose pressors and poor hemodynamics and that base deficit are things that cause us to stop. I don't know whether that's right or wrong. I think the ongoing base deficit, clearly, you take a marginal patient and take them off the ventilator and have them have to breathe and keep up with production of acid is foolhardy. Whether high-dose pressors, if a patient seems dynamically stable on the high-dose pressors, whether that should be a contraindication to extubation, I don't know. But if you're on 0.07 or of epi, we're reluctant. And I don't know whether that's right or wrong.
Yeah, I feel the same way. I would just add to the list of unstable patients you mentioned is someone who, patient who's bleeding, who's coagulopathic and bleeding. I agree. I mean, I think we've all had the experience of trying to take care of somebody who is, hemodynamically unstable and having to first worry about an airway. And that's so nice to have the airway secure so you don't have to do that and you can focus on the hemodynamics. So I agree. I think it's, and I was trying to allude to that too, because I know some of programs that will try to extubate someone to BiPAP, for example, to make the intubation numbers look good. But at the end of the day, we want to do the right thing for our patients, and that's why I do think you can extubate people too early, and it's not good practice. And I agree with the things that you both outlined.
Yeah, so maybe to summarize that, we'd all look at our protocols in a systematic way, looking at neurologic status, respiratory status, looking for hypoxemia, compliance issues, hypercarbia. We would look for cardiovascular stability, whether it was output or blood pressure, and then things like hemorrhage and metabolic matters like acidosis. Let me ask you, because I think I have some insight, but I don't have the numbers. Have you noticed in patients, whether they're coronaries or valves, that have had modified mazes, that they tend to require more inotropic support, vasopressors, and may have more profound SIRS, including acute lung injury?
We haven't looked, and we're doing more and more mazes, and it certainly hasn't crossed our mind from a data collection point of view. Why, have you?
That would be my observation. And so what I tell you is it looks like they probably have a higher rate of non-invasive positive pressure ventilation utilization, may be more challenged with supplemental oxygen even if they don't get to non-invasive positive pressure. Certainly the inotropes, vasopressors for a longer period of time, and I would think also from our experience a higher rate of reintubation.
Well, that makes sense to me as well. I think, and it's the question of, is that simply, is AFib or the need for an AFib procedure a marker of a sicker patient population pre-op? And I think that's probably true, but that would be interesting to look into in more detail.
Thank you for sharing your personal experience as well as the rich institutional experience